Hello, my name is Negin. I'm a fourth year medical student at the University of Nottingham. Today I'm going to talk about laparoscopic myomectomies as part of my robotic and laparoscopic gynecology SSMs. So during this presentation, I'm going to give you a brief introduction of what the uterine fibroids are and how the possible symptoms that the patients may experience. We're going to talk about available treatment and management options, and then we're going to go step by step and discuss the four main stages of a laparoscopic myomectomies. Then we are going to very briefly discuss the recovery and complications that might arise from the surgery, and we're going to discuss what are the pregnancy outcomes for the patients who had this surgery previously. Then we are going to very briefly compare laparoscopic and open myomectomy with each other. It's very important to note that these are not the only surgical options, but these are the ones for the scope of this presentation that we're going to discuss. So uterine fibroids are benign tumors that arise from muscular layer of the uterus, which is also known as the myometrium, and they are considered to be dependent on estrogen, so their growth is hormone driven. I have an image of the appearance of a uterine fibroid here, and this is just to show you that these are solid masses. It's not like a cyst or an abscess. These are full, as you would imagine, and they're full of cells. And the histological appearance shows that they are made of made of smooth muscle cells that are not atypical as spindles of smooth muscles, as you would find anywhere else. I have this image that compares healthy uterus with one that has fibroids. As you can see on the left image, this is the uterus, and the white organ under it is the bladder. And on the right image, you can see that these black circles, those are the fibroids that are within the myometrium of the uterus of this person. And you can see how it's pressuring the bladder from the front and also the rectum at the back. I also have this image here that is, again, it's an MRI scan, and it just shows you, it's annotated, so it shows you how it can impact the surrounding structures within the abdomen and pelvis. And you can see in the right image, the sagittary, the uterus is completely pushed to the back, so it's pushing to the rectum, and the bladder is completely pushed also down. So it can really impact the organization of the organs in that area. So I have this very brief thing because we said these are made from the myometrium, within the myometrium of the uterus, but we have different sections of the myometrium. So we've got cervical fibroids, which are in the myometrium close to the cervix. Then we got intramural fibroids, which is within the myometrium. And then, as opposed to the ones that are closer to the outside, closer to the perimetrium, which they're known as subserosal fibroids, and the ones that are closer to the cavity, closer to the endometrium, those will be submucosal fibroids. All of these fibroids, they can have a stalk and protrude into the cavity or outside it, and then they will be known as pedunculated fibroids. I have some MRI images, yeah. So cervical fibroid, this is an example of a cervical fibroid that is so big that it actually prolapsed through the vagina, and it's outside of the body, and you can see how big they can get. And then I wanted to compare the intramural and subserosal fibroids. So you can see with the subserosal is more towards the outside because you can still see the myometrium of the uterus, and it's quite towards the outside. But when you look at the intramural fibroids at the top right, the fibroids are within the muscle, it's like covered all around it. So you can kind of understand the difference between them. So the symptoms of the fibroids, they're usually asymptomatic, it's worth mentioning that. But the symptoms, again, depends on the location of the fibroids, how many of them there are, and how big they are. They can lead to bleeding, whenever there is bleeding, there might be anemia, iron deficiency anemia with it. They might cause abdominal pain because, as it was evident in the MRI scans, they put a lot of pressure in the surrounding structure and organs. And with pressuring the bladder, as you can see in this image, they can cause urinary frequency. And if the fibroid is towards the back of the uterus, you can see how it can pressure the rectum and cause constipation. Some specific types of fibroids, they can increase the risk of infertility and miscarriages, as you would assume. They might protrude into the cavity of the uterus and don't allow it. And also during pregnancy, there is an increased risk of preterm labor and postpartum hemorrhage because these are vascular tumors. And also myometrium is highly vascular. There's so much blood supply to it, so it can cause a hemorrhage. They're usually diagnosed by pelvic exam, followed by a pelvic or vaginal ultrasound. Sometimes they require MRI to get a better picture of everything. This is an example of an ultrasound. As you can see on the left, this is like a normal uterus, and on the right, you can see the fibroid. It's shown with the red arrows. Very rarely, they might do a biopsy. This is to rule out the uterine sarcomas. These are very rare cancerous uh, cancers of the myometrium of the uterus. They're very rare, but they're very aggressive. So if they suspect it, they might do a biopsy to rule that out. But again, it's very rare. So for treatment and management, because we said their growth is hormone driven, so we got medical treatment. Again, going around the hormonal. So we got a hormonal contraceptive, hormonal coil, we got combined oral contraceptive pills, and we got GnRH treatments. There are procedural ones, which is different from surgical because it's not as invasive. Procedural one, though, it's like a radio frequency ablation and ultrasound extraction. And also we got uterine artery embolization. Basically, you're cutting off the blood supply to it. If there's no blood supply, it will shrink and it will stop growing. But again, this might impact the fertility because you are cutting the blood supply to the uterus. It's not certain because there is collateral blood supply, but it might impact the fertility. Surgical approaches is myomectomy, which we're going to discuss today. Just removal of those fibroids, or hysterectomy, removal of the uterus as a whole. Obviously, with myomectomy, there is a risk of recurrence, which hysterectomy might not have that risk. So now I'm going to talk about the steps, the four main steps of a laparoscopic myomectomy. So with any surgery, any laparoscopic surgery, the first step is to position the patient correctly and insert the port. So you get like an eye inside the patient because you need to know where you're going. So you position them correctly. You insert a uterine manipulator just so you can control the movement of the uterus, and you do a camera port near the umbilicus and three lower ones. You have to make sure to be careful when you're inserting the ports because the uterus is bigger than the normal than the healthy individual that you're used to. So you have to make sure when you're inserting the ports you don't accidentally damage the uterus because again it's very vascular and it can lead to hemorrhages. Second step is to lower that blood supply to it because you want to make incision into the myometrium and you don't want it to bleed out because it will be very hard to control. So they usually use agents such as laser pressing to limit the bleeding. And on picture A here, you can see how it's whiter than you would expect it, and that's because the blood supply has been cut off temporarily. Then you make an incision into the myometrium, and then you have to find out how deep you need to go because you need to have access to all surrounding of the fibroid to cut around it and enucleate it. So if once you found the correct plane, then you can start cutting around it. And then once you removed it from that myometrium that is left is known as the myoma bed, and that's picture C here. So you have removed the fibroid, and that's the remainder of the myometrium there. As you can see, it's stretched, it's bigger, it has like an empty space. That will lead to a third step, which is reapproximation of the myoma bed. You have to put it back together because we want to preserve fertility. They might need to get pregnant again, and you want to stop the bleeding. To put them back together, it's important with myomectomies to know because you've cut through so many layers. Just one layer of suture is not enough, so you have to suture back every layer. So if you have actually got to the endometrium, you have to suture back the endometrium together, then the myometrium in several layers, and then the perimetrium. And one of the sutures that is known to be kind of like better ways because this reduces the chances of bleeding after it's a baseball suture, which is the picture here. It's a type of suture which you can look up to, and it inverts the wound, so there's less chance of them breaking and bleeding later on. Now, the fourth step is getting that fibroid out of the abdominal cavity and pelvic cavity. Um, So it's important to know because these fibroids are quite big. It's very rarely that you can take them out through the ports that you went in. So there's different ways you can do. You can do a vaginal extraction. That's for when you have several myomas through your ports and laparoscopic ports. You can connect them with sutures, and then you come out. You make an opening through the posterior vaginal fornix, and then you can feed that string of interconnected fibroids together and pull them out of that opening in the vagina, and then close the vaginal opening. This is this has been used a lot. And also another way is to morcellate it, basically chop it up into smaller pieces. There is one that is called in-bag manual morcellation. Basically, as shown in picture A, you put them in the bag and you start cutting it into smaller pieces. That's manual. It's a bit time consuming because you have to cut it individually by hand and make it smaller. Or there is power morcellation, which is basically the electric version of it, and make the fibroid into this smaller pieces you can see on picture B. However, nowadays they very rarely use the power morcellator because to do this, the machine makes aerosolizes the cells and it spreads it and also makes it smaller. And there have been cases that this fibroid, they thought it was a fibroid and it turned out to be sarcoma. And by doing that, they spread cancerous cell across the abdominal cavity. So you don't want to do that. So nowadays, with the ones I've seen, it's mostly in-bag morcellation. That will be it. Once it's in the bag, you can take it out. Some complication, as with any other surgery, there is always complication of infection, either the surgical side or inside, and formation of abscesses, hematomas. Again, with any incision, there's risk of hernia, incisional hernia. While you're in there, because it's quite a limited space, there is always risk of damaging the nearby organs and vessels. And again, with any other surgery, there is a risk of adhesion forming and causing problem later on. As it comes to future pregnancies, obviously compared to hysterectomy, you are preserving fertility, and they can get pregnant. The patients can get pregnant and get delivered. Only very slightly miscarriage risk is increased in patients post myomectomy. Not that much. The only thing that there is a risk of uterine bleeding and uterine rupture, so you have to have that in mind during the procedure, and maybe sign up for an elective C-section, so there's not much pressure on the myometrium. And now to end it, I'm just gonna very quickly compare open and laparoscopic myomectomies together. With any laparoscopic surgery, it is a longer process to learn because it's very technical and it needs a lot of skills, as opposed to open. And because it's laparoscopic, it will be a much longer procedure compared to an open myomectomy. However, open myomectomy, because it is open, you get a lot of tactile feedback, which might help the surgeon find the plane better, the plane that which level they should cut into to remove the fibroid out. But again, although open myomectomy is shorter and you have that tactile feedback, because you have a larger incision, there is longer recovery period, more risk of infection, more risk of bleeding. So it's pros and cons between them. But it's good to know that neither of them have been known to have significant impact on future pregnancy, which is what most people will be concerned about. So as a summary, during this presentation, we discussed what uterine fibroids are and how they will impact the patient. And most of the times, they won't need removing, we leave them in. And only when it causes complications, that's when we opt in for surgery or procedure to take them out or shrink them. We discussed the management options, as I said, and we went through the 4 steps of laparoscopic myomectomy, which was positioning the patient and putting the ports in, and then enucleation, and then putting the myoma bed back together, and then taking the specimen out of the body cavity. And we closed up with talking about a little bit about complications of it and comparing it with open myomectomy. I hope this presentation has been a little opening into the world of laparoscopic myomectomy, which I personally find very interesting. And thank you for your attention.